Welcome to the EAU podcast.
Good morning. I am Jennifer de Guévelou and I'm a radiation oncologist in France. And today we are with Professor Pierre Blanchard, who is the PI of the PEACE-2 study that was recently presented during the ESTRO meeting. And today we are going to talk about the final results of this study. Thank you, Professor Blanchard, for being here. Could you tell us more about the background and the rationale of the study?
Sure. So first we have to remember that this study was designed in 2012, so 14 years ago. At that time, staging was mostly based on conventional imaging and MRI for the local staging. So very high risk local prostate cancer at that time was defined according to the D'Amico criteria as having two or more risk factors among T3, T4, Gleason 8 to 10 or PSA above 20, and patients included on the trial had to have no detectable nodal or metastases per conventional imaging. A small proportion of those patients also had a choline PET-CT, but it's 18% of the population overall. The standard of care at that time was long-term ADT plus radiotherapy, and the trial aimed to answer two questions. The first one was the intensification of systemic therapy using chemotherapy, cabazitaxel in that case. And the second was the use of pelvic radiotherapy. And because we're specifically talking about pelvic radiotherapy, we have to also remember that at that time, some institutions, very famous, and some countries never used pelvic radiotherapy, even in patients who have a very high risk of nodal extension, such as the patients included in the PEACE-2 trial. And that really supported the equipoise to randomize patients with or without pelvic radiotherapy, and also because the randomized trials that evaluated pelvic radiotherapy before PEACE-2 were all almost negative. So those were the two questions of the trial at that time.
Okay, and what was the design of your study?
As I said, PEACE-2 is a trial that asks two questions. So it's a factorial 2x2 design. The patients included had very high-risk prostate cancer, as I just briefly mentioned. So at two or more risk factors among Gleason 8 to 10, T3, T4 disease, PSA 20 or above, and N0, M0 on conventional imaging. And they were randomized to receive standard of care, which was prostate-only radiotherapy to 74 or 78 gray, plus 3 years of ADT. Then half of them received cabazitaxel, neoadjuvant cabazitaxel, and half of them received also pelvic radiotherapy. The primary endpoint was clinical PFS, so clinical progression-free survival, defined as unequivocal local or regional recurrence, metastatic recurrence, or death from any cause. The trial aimed to include 1,048 patients, assuming no interaction between the two treatments tested. But the accrual was a bit slower than expected. However, the sample size, the target event rate was maintained, and so the power of the trial was not affected by the decrease in the accrual rate and the decrease of the patient number in the end included in the trial.
So, Pierre, can you tell us more about the results of the PEACE-2 trial, and more specifically, what is the impact of whole-pelvic radiotherapy on oncological endpoints?
Sure. Before jumping to the results, let me just briefly mention the standard of care that was used in the trial. So at that time, it was prostate radiotherapy, 74 to 78 gray, using IMRT. IMRT was mandatory. The radiotherapy had to start with 3 months after the randomization, and hormonal therapy was given for 3 years. So it was a long-term hormonal radiotherapy. And pelvic radiotherapy fields were defined according to the GETUG guidelines. So it was between 46 and 50 gray, and it would cover the obturator level, internal, external iliac, up to 2 centimeters of common iliac nodes, and the presacral area. So it's a bit smaller than the current RTOG recommendations, but still significant and consistent with the guideline at that time. So jumping now to the results, we included 761 patients between 2013 and 2021. At the data cutoff, 260 events had occurred, which is more than the 247 that were needed for the statistical hypothesis. And the median follow-up was 7.3 years. And as you know, in factorial design trial, we have first to test the statistical interaction between the two randomized treatments. And there was absolutely no interaction between the effect of cabazitaxel and the effect of pelvic radiotherapy, which allowed to make two separate trials out of this unique trial. So the patients were quite young for prostate cancer patients because median age was 66 years. 90% of the patients had T3, T4 disease. Almost 80% had Gleason 8 to 10 disease, and median PSA was 22. So 80% of the patients had 2 D'Amico risk factors and 20% had 3 risk factors, which if we compare to STAMPEDE high-risk criteria, makes that 81% of the patients could qualify for a STAMPEDE intensification. And if you look at nodal risk per the Roche formula, the risk, depending on how you use and how you compute the formula, is between 40 and 60% of the patients having a risk of more than 35% of having positive lymph nodes. So it's really a high-risk population. The results of the primary endpoint was clinical PFS, and there's a small improvement in clinical PFS with the use of pelvic radiotherapy. The hazard ratio is 0.81 with a p-value of 0.09, so it's negative, but it's close. At 7 years, for example, the pelvic radiotherapy arm had 67% of CPFS compared to 62.9 in the control arm with prostate only. That's clinical progression-free survival, meaning that the events are local or regional relapse, metastatic relapse, or death from any cause. If we look at secondary endpoints, however, the effect of pelvic radiotherapy becomes smaller. So for biochemical PFS, which also includes PSA progression, the hazard ratio is 0.84 and the p-value is 0.17, so less significant and really not significant. If you look at metastasis-free survival, which is usually considered one of the most important endpoints in prostate cancer, the hazard ratio is 0.90 with a p-value of 0.47, so really not significant. And if you could look at the curves, you would really see that they are completely superimposed. And looking at prostate cancer specific survival, the hazard ratio is 0.95 with a p-value of 0.86, so really zero effect on that, and of course, no effect on overall survival. So really, the trial shows a small trend in terms of improving clinical PFS, but nothing in terms of meaningful clinical outcomes like MFS or prostate cancer specific survival, and which really makes us doubt whether pelvic radiotherapy is useful in patients with such a high risk of relapse.
Indeed. And you said that the staging was not performed using imaging like PSMA PET-CT. A small proportion of patients received choline PET-CT, like 17% of the patients. We know that now this population of patients would receive PSMA PET-CT as a staging modality. How do you think that this affected the results of your study?
That's an issue that's always an issue in localized prostate cancer clinical trials, because basically the results come 10 to 15 years after the trials are designed. So we always face an issue of interpreting trials that have been designed 15 years ago and with changes in treatment management and also in staging procedures. So that's something that we always have to face when interpreting a localized prostate cancer trial. So that I think that's the first point. The second is that if anything, the use of more advanced imaging like MRI 15 to 20 years ago, and now PSMA PET-CT, if anything, it does a stage migration, which will actually decrease the risk of patients who will be considered node negative. So we know that PSMA PET-CT has quite a low sensitivity to detect nodal disease in patients with node-negative prostate cancer. And so I would say that if a patient currently with very high-risk prostate cancer has nodal disease as PSMA on PSMA PET-CT, then probably we should treat the pelvic lymph nodes. But if the PSMA is negative, the risk of occult disease remains because the sensitivity of that imaging is not perfect. But then the benefit of nodal radiotherapy is probably negative. So I think that the PSMA PET-CT will help us, will guide us in choosing the patient for which we can treat the nodes. If the patients are PSMA node negative, then probably we should not treat the pelvis, acknowledging that some of those patients will have nodal extension, microscopic, and then we will need to treat them later on if the PSA recurs.
Yeah, this answers my next question, which was, is there still a population of patients from whom you would perform whole-pelvic radiotherapy? And I do believe also that if you have PSMA PET-CT staging, you can base today your treatment strategy on this kind of imaging. But well, I'm a bit surprised to see that there is absolutely no benefit in the addition of whole-pelvic radiotherapy, because these patients are, as you said, very high-risk patients. And we know that some of them had a positive lymph nodes. If you use PSMA PET-CT, there is a small proportion of patients who will have positive lymph node. Do you think that the ADT duration was enough and might have enabled to eradicate all the positive lymph nodes that would have been found on PSMA PET-CT? Do you think that in this population of patients, long-term ADT is enough to treat a potential micrometastatic involvement in pelvic lymph node?
I think it's an excellent question. So what is the curative potential of long-term ADT? That's something that had been debated for a long time, like 15 years ago. I always believed that ADT was only palliative, so it has a potential to synergize with radiotherapy, but as a sole treatment would not cure those patients. My answer comes in multiple points. The first one is that, as you know, when you give 3 years of ADT, some patients will never recover the normal testosterone level. So maybe some of those have been long-term castrated. And fortunately, we have testosterone measurements in PIS2. So one of the coming analysis, but we have not started that, will be to look at eugonadal CPFS. So maybe there's an impact in patients who recover testosterone, and we'll see that maybe the impact of long-term ADT. Second, maybe the fact that not treating the lymph node will decrease the immunosuppression related to radiotherapy, and there may be some immune impact towards the control of the disease. So that may be also another thing to consider. And then we will have to clearly look at the site of relapse and the type of relapse that we see in the control arm, whether the majority is within the pelvis or whether it's outside of the pelvis. And that also, we don't know. We have not collected imaging at recurrence as part of the protocol. So that will be done as a retrospective study, but will be very interesting. But yeah, I think looking at the long-term ADT, what's interesting also is that in this population that is 80% stampede-like, but node negative, the prostate cancer specific survival or the overall survival are quite high. And we could doubt whether there is a need for systemic, even more systemic intensification in this population. So that's also another question.
Yeah, I do agree with you. The population of patients with very high-risk prostate cancer was defined according to the STAMPEDE trial. Well, you presented the results with the stratification according to the STAMPEDE trial. And STAMPEDE showed an overall survival benefit with the addition of abiraterone acetate and prednisone in patients that were staged with conventional imaging, so basically your population of patients. However, if we consider our current standard of care, which means high-dose radiotherapy and long-term ADT, indeed, your patients were able to have long-term disease control. So currently, what population of patients would you consider as being very high risk of relapse?
Well, it depends if you talk about systemic intensification or radiotherapy intensification. But for systemic intensification, that's a bit of another question. I think the NZARAD trial that has been presented at ESMO showed us some indications that probably only patients with clinical nodes, positive nodal disease would benefit from systemic intensification. We have to remember that in STAMPEDE, it's 40% of the patients who had clinical, like conventional imaging positive lymph nodes. In our trial, it's 0 by definition. Okay, so that's the first point, and probably also the bulk of the disease, and that's very subjective. It's very difficult to have an idea of the bulk of the disease, but we see patients who have a tumor that is stage T3 because the radiologists believe that the MRI is intraprostatic extension. But when you look at the MRI, the tumor is not that big, and some patients, you have a tumor that invades half of the prostate or 2/3 of the prostate, and it's a huge local burden. And for sure, those patients have different risk, although they can be stage T3 similarly. So, and that's something also an information that is very interesting and that we don't have in the PEACE 2 trial. So we would need to go back and look at the MRI scans because all of those patients had an MRI scan, but that would be interesting. And probably patients with a very high local burden, big T3Bs, maybe benefit from systemic intensification, but that's a pure guess. I have no data to support that.
Indeed, there is frequently the debate in tumor boards about the burden within the prostate gland. I know that within the NCCN classifications, we take into account the number of biopsies that are positive. I do believe that something that might be underassessed is the length of the tumor within the prostate gland. So maybe I agree with you. This is something to take into account. And maybe this is also the population of patients that really have a benefit of dose intensification within the prostate gland. Maybe indeed for the treatment, systemic treatment intensification, maybe the best population to look is the population that have node positive prostate cancer, either within conventional studies, but mostly now using PSMA PET-CT. So completely agree with you on that. Well, thanks a lot for your time, Professor Blanchard. And
My pleasure.
Thank you for listening to this podcast today, and see you very soon with other protocols and trials.
Thank you for listening to this episode of the EAU podcast. To keep up to date with the latest developments in prostate cancer, visit our educational platform, UROONCO Prostate Cancer. To stay informed about advances in urology, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.